Hi, my name is Sibyl Carvalho. I'm from Brazil. And first of all, I'd like to thank you for this organization and for inviting me to be part of this project. And it's a pleasure. Today, I'm going to talk about intrahepatic shunts in small animals. In order to understand intrahepatic portosystemic shunts, I'd like to review with you some important points about vascular anatomy and portal vascular anatomy. Okay, so let's do it. The liver is the largest internal organ in our patient's body. It lies in close proximity to other organs, such as the gallbladder, which is under it, and the stomach, which is to the left of it. The liver is located in the cranial abdominal cavity under the ribs. It has 4 lobes and 4 sublobes. Gallbladder is connected to the liver through cystic ducts and small intrahepatic. The liver has a lot of blood supply in order to be oxygenated and in order to receive nutrients. So if we look at this blood supply, the liver's blood supply, here we have the aorta coming from the heart, which brings oxygenated blood into the tissues, and the oxygenated blood comes to caudal vena cava in general circulation. Aorta brings blood to all these organs: stomach, spleen, intestine, and also liver. Now, what is important to know is that once these organs has used the oxygen from the blood supply, all the deoxygenated blood and full of toxins blood are drained through veins, and actually these veins will not go back to the heart, but will go toward to the liver as a big vein named portal vein. And these veins carries nutrients from these organs, and that's how liver receives nutrients. So all this blood leaves the liver by another veins, comes from the portal veins and leaves the liver through hepatic veins. These veins draw directly into caudal vena cava here and goes back to the heart. Okay. So we know the portal vein is formed by the confluence of the cranial and caudal mesenteric veins. The trunk of the portal vein collects the blood of the splenic vein at the level where the celiac artery is originated from the aorta, and the blood of the gastroduodenal vein drains immediately caudal to the portal bifurcation. The left gastric vein is also a tributary of splenic vein and may anastomose with right gastric vein. The right gastric vein is either a tributary of the gastroduodenal vein or enters the portal vein trunk directly caudal to the gastroduodenal vein after a way along the lesser curvature of the stomach. At the hilus of the liver, the trunk of the portal vein bifurcates into a larger left and a smaller right portal branch. The right branch supplies the right lateral and caudate lobes, whereas the left one supplies the left lateral, left medial, quadrate, and right medial lobes, as we see in this diagram. Okay, portal system with right and left branches. The tributaries, splenic, gastrosplenic vein, gastric vein, mesenteric veins, and the right and left branches. Okay? So, we already reviewed this. So, portosystemic shunting occurs when anomalous veins allow the portal flow to enter the systemic veins directly without first flowing through the hepatic sinusoids, bringing all the toxins and all the deoxygenated blood directly to caudal vena cava or azygos and goes to general circulation. Acquired portosystemic collateral are formed as a result of sustained hepatic or prehepatic portal hypertension by enlargement of extrahepatic rudimentary vessels through which no blood normally passes. And collateral formation is a compensatory mechanism to maintain normal portal pressure by allowing the portal blood to be drained into the lower pressure systemic veins. Portosystemic shunting is considered to be congenital if a single or double anomalous vein is presented without a concrete portal hypertension. There is no portal hypertension in congenital shunts. And congenital shunts are classified as intrahepatic and extrahepatic shunts. So let's see the intrahepatic types of shunts. Intrahepatic shunts tend to occur more often in large breeds and result in hepatic encephalopathy, usually under the age of 1 year or 2 years. The etiology of intrahepatic shunts remains unknown, except for the left-sided intrahepatic, this one, left side intrahepatic, which is believed to be a persistent of ductus venosus. This shunt that originated from the left branch always runs cranially and ventrally and to the left, similar a normal left branch, left portal branch, until the diaphragm. Then turn it as a curved vessel like this, turn it abruptly dorsally to enter to caudal vena cava via a dilated segment of the left hepatic vein. Often in these dogs, the right one, the right branch, is abnormal. We could not visualize it, all right? Intrahepatic shunts that originated from the right, this kind here, from the right branch, usually has a segment that consistently runs dorsally and to the right from the portal vein, like a normal right portal branch. But then, instead of ramifying to irrigate the right lobes, turn it medially, like this, arrow here. Turn it like this, medially, to enter directly to caudal vena cava. And the third type of congenital portosystemic shunts is named as central intrahepatic shunts. This is a diagram of this. Central intrahepatic shunt is originated directly from the main portal vein that turn it and enter also directly to the caudal vena cava. And both branches are abnormal or even not exist. Let's see how these all types of shunts appear in ultrasonography images, okay? So first of all, we have to say that the best window to make these diagnoses are right intercostal window and paracostal window, where we can obtain transverse and sagittal plane respectively, right? So here we can see this transverse image across intercostal window, and we see portal vein, caudal vena cava, and aorta. If we color map with color Doppler, we see portal vein, caudal vena cava, aorta, and also hepatic veins drowning into caudal vena cava. That is normal architecture of the portal hilus. In sagittal planes that we can obtain in paracostal window, we also see portal vein and caudal vena cava, but in sagittal planes. So we can observe here caudal vena cava and a right branch running directly to the probe, to the sound. And in another angle, we also can see before this branch, caudal to this branch, the gastroduodenal vein here draining into the main portal vein, okay? And at this level, we can also see portal vein and caudal vena cava, and sometimes it depends of the size of the animal that we are seeing assessment. We can see also aorta, okay? In the small ones, we see also aorta. So let's see some examples of intrahepatic shunts. We talked that we can see the right ones, the left ones, and the central ones. So let's see this example. First of all, in B mode, already on B mode, we can see this abnormal vascular architecture at portal hilus. So on B mode, we already see that something is wrong, okay? So when we put color Doppler with color mapping, we can observe the right branch running dorsolaterally and going to the caudal vena cava, and like a normal branch, but instead of ramifying and re-irrigate the right lobes, turn it into caudal vena cava, and we can see the direction of this blood with the color in red going up and blue going down, and this mixing of colors, it means that if something is wrong, something is turbulent, so it's draining into caudal vena cava abnormally. Let's see again another case of right shunt, intrahepatic shunt. We see the right portal branch going normally, but instead ramifying, turn it and going down and enter directly to the caudal vena cava. We can see the same patient, but now in Doppler, and we can observe better the direction of the flow, the blood flow, going up and then going down, draining into caudal vena cava. Another type of intrahepatic shunt is the central one, central divisional shunt. We also can see on B mode that something is very wrong here, because portal vein is connected by an anomalous vessel, and caudal vena cava is connected by portal vein through this anomalous vessel. Okay, but to be sure of this, a normal vascular architecture at the portal hilus, with color mapping, we can observe this connection with blood flow and a turbulent flow between portal vein and caudal vena cava, and with the blood going into this direction, entering into caudal vena cava directly. And there is no more vessels detected here, so something is very wrong here, and this is an intrahepatic central divisional shunt. This is another example of the same kind of shunt, where an anomalous vessel is connecting portal vein and caudal vena cava here. The third one is the intrahepatic left divisional shunt that we can see here again, and on B mode we can see that something is wrong. There is an abnormal vascular architecture at the portal hilus here, and the portal vein originates this left branch, and the left branch running ventral laterally, turning into caudal vena cava. It's easy to see with color mapping because we can see the direction of the flow, so we can be sure about this wrong direction and the wrong architecture. So we can see better here. We can have a suspicious here with the anomalous vessel here and the portal hilus. We think what is going on. The portal vein is originated the left branch, but the left branch instead ramified and irrigates the left lobes, turn it in this direction that we can see here, turn it in this direction and going down here to the caudal vena cava here. Okay, so in conclusion, we can say that intrahepatic congenital shunts can be detected on B-mode image, but hemodynamic repercussion assessment can be performed only using duplex Doppler ultrasonography. So I hope you enjoy it and you understood all these 3 types of intrahepatic shunts, and I hope see you again on one of these media, this social media, or even in Brazil, who knows? Thank you.